of the April Board of Directors to order. And if I could have our General Counsel read us out of closed session, please.
Yes, thank you, Chair Wong. The board considered 7 items in closed session this evening. There was no reportable action on items 5.1 and 5.2, which were Health and Safety Code 32155 hearings. With respect to item 5.3, conference with legal counsel regarding the receipt of a claim. The Board of Directors approved rejection of the claim from Streamline Construction on a vote of 5-0. The substance of the claim relates to alleged damages arising out of construction projects. With respect to item 5.3, also a conference with legal counsel, the Board of Directors approved a settlement. They approved the settlement of potential litigation with Alliance Physical Therapy Group and authorized the President and CEO to sign the settlement. The vote was 5-0 in favor of approval. The settlement allows for the early termination of the hospital staffing and management services agreement between Tahoe Forest Hospital District and Alliance Physical Therapy, which was otherwise set to expire April 30th, 2023. Under the settlement, Alliance will allow Tahoe Forest Hospital District to hire specified Alliance employees that are currently providing services to Tahoe Forest in exchange for a separation payment from the district to Alliance in the amount of $1,064,218. That's item 5.4. Item 5.5, which is conference with labor negotiator. That labor negotiator is Alex McClellan, HR director. There was no reportable action. Item 5.6, the closed session minutes of March 24th, 2022 were approved on a 5-0 vote, and the medical staff credentials, those recommended credentialing decisions, were also approved on a 5-0 vote. That concludes my report.
Thank you so much. Are there any deletions or corrections to the posted agenda? Anything from our audience? Then we'll go ahead and move on to item 10, and this is input from our audience. And I just want to give some ground rules. This is an opportunity for members of the public to address the board on any item which is not on the agenda. If you wish to give comment, please raise your hand or use the icon on the bottom of the Zoom screen to let us know that you'd like to speak. When addressing the board, please state your name for the records and keep your comments to 3 minutes. And I do apologize in advance if I have to cut you off because of the time limit. If you wish to write comments to the board, you can submit those to the board clerk 24 hours before the meeting. And just to let you know, we cannot take any action on anything brought up during the audience input because it has not been agendized. So do I have any comments from our audience? Guess I scared him off with my rules.
Just to reiterate, people who are interested in making comments can use the raise your hand function, right, which is located on your bottom toolbar under reactions.
Mm-hmm. Okay, then we'll move on to input from the Employees Association, and that also is covered under the same rules. So do we have any comments from our Employees Association?
Hi, my name is Sonia Henry, and I'm on the board of the directors for EAP. I'm the acting treasurer. Can you guys hear me?
Yes.
Okay. I believe do you guys see Tyler Kavanaugh also on the call? No. I was going to introduce him. He must be having technical difficulties. Anyway, he is the new president of the EA, and I wanted to introduce him. He was supposed to be on the call. Just wanted to let everyone know that we've been working really hard on the new contract. I sit on the negotiation teams with Tyler and the rest of the negotiations team, and I'm a big thank you to both sides. It's been a really nice team to work with. And I wanted to give one shout out to Dr. Cole, that she's done an amazing job as our CMO, and that we will very much miss her.
Thank you, Sonia. I really appreciate the work that you guys do with the EAP and everything, and appreciate all your work, hard work for the district. So thank you.
It was great having an employee come to the meeting and address us on what's going on with him. So thank you very much, Sonia, for doing that. I'm sorry that we missed Tyler, but maybe another time. Okay, thank you again. And then we'll move on. If anybody has any, I guess we don't do comments. We'll go to the Medical Staff Executive Committee. We have Dr. Koch.
If Dorothy could share her computer screen so that we have our agenda up.
Sure. Let me try. I'm sorry, I'm experiencing a little bit of a lag, so I will try here. There we go.
Awesome. All right. So to start out with, there are one privilege change, 3 policy changes, and medical staff rules and reg change, and a new policy. But the first of those, the first 6 of those are all related to Leadership Council Committee formation, which is a new thing that we, as a medical executive committee, voted in as of our last meeting after having sent out information to the entire staff and requested input. And the Leadership Council formation means that needs to go into our professionalism policy, our emergency privilege. No, the emergency privilege is something else, sorry. But the professionalism policy, the peer review policy, the well-being policy, and the fitness for duty policy. The primary changes in each of those are to add in the Leadership Council Committee and then remove any duties that used to belong to somebody else, like the well-being committee used to have investigatory mandate, and that's no longer there. So we can go through them in detail, but just to give you an overview of what that's about. Shawnee, did I get that right?
Yes, thank you, Dr.
Okay.
Koch.
All right. So starting then from the top, which is emergency room privileges form. Again, now that we are a level 3 trauma center, woohoo! All the ER physicians are required to have ATLS requirements at least one time as emergency room employees in a level 3 trauma center. So all of our ER docs will now be required, and that's the only change in the emergency medicine privilege form. Any questions about that? Just a big shout out to all the people who got that to happen.
Yes.
Yes.
Yeah. Huge,
Absolutely.
huge undertaking. And then with regards to the professionalism policy, do you want me to open each of the policies so that we can review the changes, or just, I know you've had a chance to read through them. Probably the biggest change was with the Wellbeing Committee, where they no longer have investigatory role at all. And I think you understand the purpose of the Leadership Council Committee, but it's basically intended to make the department chair roles and the medical executive committee roles a little bit less onerous, but also separate medical legal issues from becoming legal issues to the extent we are able for physicians, so that we have more flexibility in how we address concerns with physicians that could lead to reportable events without putting our leadership in each department on the hot seat. So any questions about the policies changing? All right, great. And then the next thing is the change in the staff rules and regs, which is where we added the Leadership Council. Again, any questions there? I know you've had a chance to read through it. No? Okay. And then finally, the Code 250, which is again a great shift for the hospital. It is what's going to allow us to have our own emergency respond to emergencies, medical emergencies that occur on the second floor or the first floor of the cancer center, as well as in the parking lots that belong to the hospital, as opposed to having to call 911 and have an ambulance bring them the 200 yards or 100 yards into the emergency room. And this will be a service to everybody involved. And so this is getting rolled out hopefully early next month. Shani, did you want to add anything on that? Okay. All right.
No, thank you.
Does anybody have any questions on this?
Nope.
Dr. Polk, I want to thank you though for going through those. It was very hard to read those policies because they're in the tracking form. So it was difficult to figure out what was printed and what was crossed out. So thank you again for going through each of those for us.
You bet. Absolutely.
Any comments from our board about any of the policies?
Director Barnett, yeah, I appreciate your getting the reason for those changes and how they will work. As Director Wong points out, when you read through all the details, you can kind of get lost in what you're trying to accomplish. So thank you for that.
Any comments from our audience on the consent agenda of the Medical Executive Committee? So hearing none, can I have a motion to approve the Medical Executive Committee consent agenda as presented?
Alice, this is Mary. I would make the motion to approve the consent agenda as presented.
Thank you. A second?
Director Barnett, second.
So it's been moved by Director Brown, seconded by Director Barnett to approve the Medical Executive Committee consent agenda as presented. Can we have a roll
Director
call
Barnett?
vote?
Yes.
Director Barnett, Director Shamblin,
Yes.
Director McGeary,
Yes.
Director Brown,
Yes.
and Director Wong.
So Dr. Polk, your Medical Executive Committee agenda has been approved. Item 13 is a consent calendar, and these are really non-controversial reports and usually are reports from our chiefs and any revisions and policies or whatever. But if anybody is interested in pulling something, they may do that, any board member, any staff member. So is anybody on the board interested in pulling any of the items under the consent calendar?
Director Wong, I have a point of order question. I found a typo on page 83, which is the code 250 hospital emergency response team. And I just wanted to point that out. I don't know if there's anyone here who's interested or can correct that, but I just wanted to note that. Is there anyone here who's, we lose our
Is that under the medical staff?
Yeah, that was.
Yes. I'm happy to, this is Dorothy, I apologize. I'm happy if you could maybe send it to Martina. If Martina, you could send me the correction and then I can get it to Jan to update the policy with that change.
Yeah, okay. It's just a typo.
Okay, thank
it says
you.
R and should be area.
Okay, so again,
Okay.
that'll be taken care of through Martina to Dorothy. But the real question is, does anybody want to pull anything? Any staff want to pull any of the items? Okay, if not, can I have a motion to approve the consent calendar as presented?
I'll move to approve the consent calendar as presented.
Can I have a second? Thank you, Michael. I'm sorry, Director Barnett, did you approve it?
Yes.
Okay, so it's been moved by Director McGarry, second by Director Barnett to approve the consent calendar as presented. Martina, a roll call.
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGeary,
Yes.
Director Brown,
Yes.
Director Wong.
All right, then the consent calendar has been approved as presented. Moving on to 14, this is a item for board action, and it's resolution 2022-10, and it's in regards to the hospital district general election. And Martina will go over that resolution for us.
Sure. Martina Rochfort, Clerk of the Board. The resolution before the Board of Directors tonight is to consolidate the hospital district general election with the statewide general election, and then authorize the canvass of returns by the respective boards of supervisors of Placer and Nevada County. This is a standard resolution that you approve a few months before every election. The district needs to get it into the counties by July 1st, and it states who on the board is up for election this year. And this year we have 4 seats, 3 on regular terms and 1 on a short 2-year term. And those terms expire Friday, December 2nd. And we'll be having our election on November 8th. Do you guys have any questions? It's a fairly simple, straightforward resolution that gets approved before every election. And General Counsel has reviewed it as well.
Comment? Excited?
Yeah.
You're the only one.
Yeah.
Are there any comments from
I'll
the
say safe one.
audience? Yeah. Okay. Then can I have a motion to pass resolution 2022-10? Again, it's something that we do before every general election, that we have candidates running from the district.
This is Director Barnett. I move that we approve 2022-10.
Please.
I'll second the motion.
Moved by Director Barnett, second by Director Brown, that we approve resolution 2022-10 regarding the hospital district's consolidation with the general election. A roll call vote.
Director Barnett.
Yes.
Director Shamblin.
Yes.
Director McGeary.
Yes.
Director Brown.
Yes.
Director Wong.
The resolution has passed. We'll move on to item 15, and it's for board discussion. Last month, we saw part 1 of population health, which is on a platform of iProtean, a educational platform for board members. And today we're going to see part 2, and we'll have a discussion about some of the content and what can be done for population health. So Martina, can you get the video for us?
Welcome back, Dr. David Nash. Glad to see you. Thank you for joining us. For those that are meeting with Dr. David Nash here with us today for the first time, he is the founding Dean Emeritus of Jefferson College of Population Health. It's a privilege to be with you, and we want to hop back into the second part of a 2-part micro-series on population health and health management. So, David, we want to talk today more specifically about applying population health tools and focusing more specifically on the tools. Provide us a little snapshot on Pop Health for those that are joining us for the first time, and then let's hop into minimizing waste in the healthcare system.
Great. So population health is not a new term, something that's been around almost for 20 years, but certainly has achieved prominence, especially in the last 5 years, as we've started to implement some of the tools of Obamacare. So population health explicitly recognizes that it's not about actually going to the doctor. It's all about the social determinants, where you live, what your income level is, your education, choosing your parents wisely. That could be helpful as well. But that there's great disparity in our country and great inequality. And these are some of the key drivers of the lack of health in the population. And population health also asks the question, how do we reconcile the fact that we commit $3 trillion a year to healthcare, roughly $10,000 per person, including children, and what is the outcome? What's the return on that investment? Meaning that we're really not in the top 10 of any measure of health as it relates to most of the other Western nations that track these kinds of things. So population health, in my view, is all about how do we reconcile this mess, and what are the tools and technologies we might use moving forward that might reduce the mess, reduce the jam that we're in.
Understood. So let's talk about what tools we can use that will begin to minimize this waste.
Okay. Well, so let's first describe the 3 types of waste we talked about. So one type of waste is individual behavior, obesity, smoking, the diseases of despair. Operational waste, trying to implement an electronic medical record and how challenging that really is. And then the most important, in my view, is clinical waste. And under that category are 2 important things: medical error and unexplained variation in how doctors tackle the same exact clinical problem. Mm-hmm. So I would start with clinical waste and how do we tackle that? So first, I think the most important thing is giving physicians really good feedback on their own performance in a non-punitive way delivered by a local leader. And when you give doctors good feedback on their own performance and show them how to do a better job, they're going to stampede to improve. So board members need to provide the resources, chief physician executives, the registry function, clinical training, training in pop health, all of the above, to help doctors understand where they are and how they might improve their own performance.
David, are you seeing very favorable examples of these success stories here in the States over the last few years, or can you share one with us?
Sure. So I think we're on the road. I think we're inexorably on the road from volume to value. And some of the tools that we're using to sort of, continue to chug along on this road, things like a bundled payment, where we're recognizing that when you're at economic risk for a clinical decision, you may choose a less expensive antibiotic. You may send somebody home with appropriate care coordination. So the nuts and bolts of population health are not that complicated. It's coordinating the care, it's connecting online and text messaging and email, it's having a team approach, not just the doctor as the captain, but lots of other players who are working up to the level of their license. And of course, it's getting good information out of all the data that we're collecting and asking some different questions, like instead of how I was trained to practice primary care, here's your list of patients, get busy. You're asking a population health question like, well, who's not here today who really ought to be? And maybe the answer to that question, who's not here and ought to be, is something that we learned from the bus driver who went to pick up the patients, and Mrs. Jones isn't on the bus because the elevator in her building's broken and she can't walk. Well, wow, we wouldn't really understand all of that in a fee-for-service world, but in an economic risk bundled payment world, capitation, whatever you'd like to describe it, all of a sudden now we have an economic incentive to go and get Mrs. Jones and figure out what's wrong.
Yep. So it sounds like to me that a hospital organization, as you referred to in our first conversation together, Peter Drucker acknowledging it as one of the most complicated organisms or organizations on the planet, right? Recognizing this, it sounds like the 4-wall hospital of the future is no longer going to be a 4-wall organization, that the tentacles are going out.
It's a great example. So let's use the Jefferson Health System as one of the examples. Certainly there are many out there. But look, in the last 5 years, Jefferson has gone from really 2 hospitals to 16, soon even more. And I know that Dr. Klasko, our enterprise leader, he talks a lot about care anywhere, and Jefferson everywhere. And so what does that really mean? Well, it means we just had our 100,000th video visit. That's amazing. And when I look at my 3 millennial children, I mean, they're never going to, call the doctor, get in a car, wait in a waiting room. Are you kidding? They'd rather have root canal without anesthesia. So it ain't ever.
Feels like the Flintstones.
Indeed.
Yeah.
So care anywhere is part of population health, telemedicine, connectivity via text, via email, closure of the feedback loop to the practitioners, care coordination, getting deep into the office practices of the offices we either own or co-manage or we have a joint venture with, getting into those offices and looking at process improvement. What do we do every day here? How can we do a better job? How do we reduce waiting time? How do we reduce waste? How do we reduce error? And all of this can be done. I think it takes a very important and strong commitment on the part of the board, because they have to reorient folks. This is a new way of practicing.
David, how do we inspire that board?
Yeah,
for this example, I want you to talk more about how the impetus, and you sit on boards of hospitals, yes, as well as any.
Well, so speaking as a former hospital board member of 2 systems for more than 2 decades, I feel their pain. How do we inspire boards? Well, I think one is just recognizing that the platform is not just smoldering anymore, but it's starting to really burst into flames, and that the old approach is probably not going to continue to work, given that we're starting to spend, $1 out of $5 in the GDP on healthcare. That's really not a sustainable ratio. And I think even more fundamentally, boards have to ask the question, what is the business that we're in? If it's the business of improving health, well, then, I wouldn't give us a very high grade based on the evidence that we've got in the marketplace. So to stimulate boards, I think they just have to look around and say, well, what kind of care do we want to get in the future? Do we want coordinated care? Do we want care that's going to go upstream and shut the faucet? Or do we just want to keep building buildings and try to get heads and beds in 3 or 4 key specialties? Not everybody is going to be able to, moving forward, rely on cancer, neurosurgery, and orthopedics. We know this. Yeah. To think that every organization is going to have that same strategy, well, that's just knuckleheaded.
Yep. And so it's preventative, right? It's yes, intercepting prior to and be involved in the whole continuum, but everything preceding getting to the hospital. I'm hearing nutrition. I'm hearing the critical importance of your socioeconomic circumstances, and as you said earlier, your zip code and where you live and all the surrounding environmental factors. So is this to say that healthcare is going to eventually find its way into all things health?
Well, I hope that the blue hospital sign of the future will not only stand for hospital, but it'll stand for health and hope. I mean, that really is my dream, and that we're going to get there on this road from volume to value by, seriously looking in the mirror and asking ourselves a couple of very tough questions. What's the mission that we're really in? What are our real values? How are we spending public money, after all? And what's the grade that we're getting? Ultimately, it's going to lead to what we call a no outcome, no income world, meaning you got to achieve the outcome measures before you're going to get appropriately reimbursed. And then we could quibble what those outcome measures are, but I think some of them need to include measures of health and measures of social engagement. What are we doing to reduce disparities? Well, that is something we could measure, and we could reward or not folks based on their level of improvement.
David, how important or significant do you think the partnership between the healthcare community and organizations, hospitals, and businesses, technology world?
Sure. So look,
talk a little bit about that, the nexus there and the need for
Well, that's a big challenge. The corporate culture of health is still a rather amorphous concept. Look, I think there's a couple of things going on. We know from the work of people like Ray Fabius and others that companies that are committed to a corporate culture of health actually return greater value to their shareholders. Mm-hmm. We know this from really good research evidence. On the other hand, we also know that engaging with the average employee is really tough to do. And whether it's we haven't applied sufficient incentives or we don't really understand behavioral economics or all of the above, probably all that is still active. Plus, we have an American culture of, I want to take my Lipitor on the way to McDonald's. I'll buy the Big Mac and I want Uncle Sam to buy the Lipitor. That is sort of still our culture. So it's kind of a witch's brew of problems, right? And also, we're the only country in the Western world where most folks get their insurance based on where they work. So this puts employers in a very tough spot. Yeah. So if they want to really establish, health as a key business component, it's an uphill battle. Recent evidence from the Milbank Memorial Fund, looking at 1,000 employers, one of their biggest challenges remains employee engagement. And there's concerns. This is Big Brother watching me. I don't want to divulge my cholesterol level to my employer and so on. So despite the fact that more than 40 cents on every dollar spent on healthcare comes from where, our employers, the employer-employee relationship, we have not done a great job in going upstream to shut that faucet where we work, instead of just, continuing to pay for all the downstream challenges.
Yeah. All wonderful stuff. David, I want to thank you for joining us. We could be talking for another hour, but you've certainly jump-started some meaningful conversation here and some opportunity for our community of board members and management to be thinking very thoughtfully about this important subject of population health and population health management. All the best to you. Congratulations. You're coming up on a 30-year anniversary, I believe, Jefferson.
Yes, sir.
So, we appreciate and applaud your work.
Thank you very much.
Thank you, David.
Registry.
Okay, so we've talked about those 3 areas of waste, and in this particular segment that we saw, it talked about some of the tools in order to reduce some of that waste. So let's hear from some of our board members as their thoughts on what's been happening and what the video brought to your mind.
Alice Dale here. I have a question. I don't understand the term patient registry. What does that mean?
Does anybody want to give him the answer? I could give it to you. It's a list. It's a registry of all their patients and what their health is so they can track them over time. Is that what you guys understand it to be?
Yes.
Hey, Louis shaking his head yes.
Yes.
Yes. That was a wonderful explanation, Chair Wong. Yes.
And I think one of the things that we were concerned about is how do you do that? And certainly we've got Epic and we have the IT component, but how do you get that programmed so that our providers can look at their patients? And again, they may have consistent patients or they may have just intermittent patients, but always looking at how are they doing? Are they getting better? Because again, what we're looking at is the improvement of health.
And I think too, Chair Wong, part of the registry is what you may hear, the HIE or Health Information Exchange. California's tried several times to get that up and running, but it's a big state, so they've always kind of dropped the ball. They try to keep it privatized. Nevada has done a good job. And what that means is it doesn't really matter what EHR you're on, but if you're on a clinical, Next Gen or Athena or what have you, but you're participating in this health information exchange. And I've met Dr. Nash several times. He worked in Maryland a lot, came and spoke at our hospital. Maryland has what they call CRISP, which is a big health information exchange. And the idea behind that registry is it's EHR independent. And if your patient shows up at an ER somewhere else, you'll get notified. You understand that Jake was in Maryland and he broke his leg or what have you. And then you, as his primary care physician, would know that. And we have a big registry with vaccinations. We just moved. It was in my board report. I'm not sure if it was this one or last month. It's a lot, but it's called CAIR, CAIR, California Immunization Registry. We participate in that, and that was an effort to get all of the COVID and other vaccinations into a state registry, so you can share that data between healthcare organizations and state-run organizations, or the airlines, or whomever.
How do you square that with HIPAA regulations?
It's all, so HIPAA has 3 rules basically. One is in the collection of bill, you can share information. So we can share information on Dale if he owes us $10 with a collection agency. The other one is in the effort to provide quality care to that patient. You can share with other providers that are directly involved with that patient care. And the third is actually for population health, the third carve out. So if the intent of the sharing is to increase population health and overall with the triple aim, reduce cost, then it is permitted.
Yeah. Alice, I'm wondering if perhaps Shawnee could give us a bit of a snapshot in terms of what kind of feedback the providers receive now with regard to their patients. And I know that's a big question, but if you could just kind of give us the highlights of that as it relates to the information we just heard.
Yeah, I think that's a really broad question for me, and I'm not sure that I have an adequate answer for this board meeting, but I can definitely research it with those physicians.
Mary, I can tell you with my frequent visits to our healthcare system and others here recently, everything that happened to me at Renown with my surgery, what have you, was all available to Dr. Semrad, and we went over it. And Dr. Trudell went over it with me, and I had a consult with UCSF, and that magically popped up in my chart. So Dr. Semrad was able to see what their opinion was based on planning my care treatment. So Epic does a good job in really sharing.
So what I would, this is Dr. Koch. I was still listening in, and what I'd like to add is that Nevada has a health information exchange across the entire state. Yeah. We are on record as participants, but we are not able to access it. And what you're talking about, Jake, is accessing information in Epic. In other words, all the providers you're talking about are in Epic. As soon as you drop out of Epic, you drop out of our access region. And so, for example, Northern Nevada Medical Center in Reno does not use Epic. We cannot see any of their records in any way. If a patient gets blood work from another provider at a LabCorp or at a Quest lab, we can't see those results.
Good place to bring it up. I will get with you after, and we can find out why you're not seeing that, because I know others are. And it may
I don't think so. I don't think anybody's seeing that. I think we're all seeing what's in Epic and nothing outside of Epic. I've been working on this for a while.
Yeah, we've been connected with the Health HIE in Nevada from the inception. We have we have an HL7 that's sent. So if they're not disseminating that data, we can call them and talk to them and find out.
I think Dr. Koch, I think that's something that the two of you need to work on.
Yeah, right.
Again, going back to Dale's comment about what is a registry. So you can see where the information is about a patient. And I guess I keep thinking, the key is to be able to have a primary care provider, that if I want someone that has that information, so that when I go to see them, they will say, well, you're getting better, or you're getting worse, or you're not, you need to do this kind of thing. And I find that now and I don't want to brand anybody, but with the younger generation, they just want it fixed and move on. They don't really care about long-term health. And I find that kind of distressing because they love telemedicine. And as long as you get the same provider, then you're good to go because they know who you are.
Right.
If you get a different provider each time you do a telemedicine, then they sort of look you up and they know you at a glance, but there's no real investment. So that it lays back on the patient. They have to be invested in their health. And like what Dr. Nash said, is like just prescribing my Lipitor. I will have my steak and baked potatoes, and I'll see if someone else will pay for it. And I want the government to pay for my Lipitor. So I mean, we have to look at changing that kind of mentality.
Well, and understanding too that this all came about when population health came out. It was a reimbursement scheme. So you had an assignment, like in Maryland, we had 16,000 pop health lives. And those were the lives we measured, and how well we treated them. Actually, it was like how little did we spend on them is really how that program works, but don't get me started on that. You want to be able to claim those patients. So you really needed a health information exchange, because if they went somewhere else for care outside of your facility, you needed to know about that so you could then claim them as being part of your population health population, so you could get the reimbursement when you, or not, if it's a zero-sum game. But if they went outside of your network, you needed to know about it. And that's really where those things started making headway.
Yeah.
Alice, my question to Shawnee wasn't necessarily about individual employees. I understand how that gets accessed, but I'm talking more about the gross data and how that gets massaged and bundled. Do the physicians know how many of their patients, more like a utilization review, or how many patients they have who have not received the COVID vaccination? How many patients fell out on this score or that, or what have you. I mean, that's the kind of information that I think we're talking about in terms of being useful to the physicians in this goal.
I was just looking at some of the standard screenings, between having mammograms done or having colonoscopies done. Do you know whether those have been done or not? Especially if it's, outside of your facility.
I mean, we have tons of data, but I guess the question is, how do we massage it and how do we use it?
Or do we even use it?
Yeah.
We're not actually getting a ton of that data, Mary, out of our system. There are a few metrics that we can get, like hemoglobin A1C levels per your patient population. Again, this is more of a primary care, and I would need to talk to them because it's just not something that I do, and I don't want to speak out of turn. But I do know there are a few data points like that we're able to use, but there aren't a ton yet.
So
But it makes
if I could just go ahead.
Just one more thing. It reminds me of a question that Michael, you asked. I want to say it's probably been 2 years ago now, is how do we measure the health of our community? And have we ever measured that? And if we don't have that, how do we establish a baseline to know whether or not we are creating a healthy environment?
Yeah, and building on that, it probably was a couple of years ago that was asked, so I don't say I remember it exactly. But Harry, I'd appreciate your thoughts on, a lot of the content that David Nash was talking about hinges on the adoption of value-based care, right? Moving away from fee-for-service. He was pretty adamant that we're well on the way there. I'm not seeing that actually. Across the health systems I engage across the country, we're still very much in a fee-for-service world where a lot of these strategies really can't be pursued financially, right? The incentives just simply aren't there. Related to our health system, our local geography, I appreciate your insights and thoughts there on sort of the move to value-based care. Is that something that would make sense for us? Where do we sit on that spectrum?
But we do have a deep commitment for value-based care. And for example, you've heard me say we work really hard to keep patients out of our emergency departments or out of our inpatient beds for illness reasons, if at all possible. And we know from a review of detailed data as we prepared our strategic plan recently, and about 3 years ago, for example, we have approximately half the number of admissions per 1,000 population for full-time residents in our region versus the state of California or Nevada or the surrounding areas that are outside of our primary service area. And there's a lot more aspects to it. The one thing that you've seen, we have a wellness neighborhood program. We have care coordinators. We have patient navigators. So we have a whole variety of team members that you won't see hardly in any critical access health system in America, not because we really get paid for all those services, but because we care about our patients. And we don't get rewarded like Anthem or Kaiser or any other unnamed large top of mind system that gets a per member per month fee where they have optimal motivation to even admit to home or any the cheapest setting for any patient care episodes. We don't get paid, when we have those kinds of savings. We don't get that dollars per member per month, but we're still deeply committed to that with these personnel that we have and their actions that you hear reports on from time to time in mental health or physical health. All that being said, our progress over the last 5 years is a small dent probably in the eventual journey, because we don't also receive all the care that all residents within our region receive. We don't know the total picture, whether they never seek health care, they use us exclusively in a minority or a majority. So we will have to figure out reasonable methods where we can learn more about residents in our population and how we can help them. We know from some of the data too with strategic planning that some populations have longer lifespans than we anticipated and may have longer lifespans than our general population. But again, these are just scratching the surface. So we're doing more than any of the other critical access hospitals. But I think, one of the ways, if people are fearful to come and see us, there may be discussions about how we go out to communities where we don't have an office, et cetera, for, and I'll use the term loosely, a mobile primary care, maybe a dental service in the future. If we can do that in a sustainable way, where we go out to them and we try to seek them out and invite them to be courageous and to see us, engage with us if they haven't in the past. So I think our Promatoras, our wellness neighborhood, where we partner with 40 or more companies, again, our agencies, these are super important. We've illustrated our deep intent and love for our community, but we still have quite a ways to go.
Mary, I apologize. I think I moved away a little bit from your question. My response is I don't know that we do know, right? We don't know what we don't know.
So if I could, I'd just like to contribute what I think is the makings of a success story. So, we brought up mammograms, of course, very important, preventative care. And although it's not easy, when we do put a lot of effort into data collection from our EPIC system, we can actually figure out what is not occurring in the community, right? So what we've been able to do recently, the director of DI has actually worked with Dr. Fountain and figured out that over 2,000 patients over the past 2.5 years have actually, at some point prior to 2.5 years ago, they had a mammogram, but have not actually come back for a follow-up, right? And we can also tell that they haven't went anywhere else. So we can look at claims data and we can see that they have not actually went to Reno or to another community to obtain that service. So what we've actually done is we are reaching out to this population with a letter kind of discussing the importance of follow-up and then offering that service. So it can be done, it's just not easy at the moment.
Thank you.
There's an example that we've had at the hospital. It was wellness at work, and there was an incentive that if you went through this process, that you would get a discount on your health insurance. And they tracked, I can't remember the parameters they tracked, but I know blood pressure was one and weight was another one. And they looked at all of those. And over a period of 3 or 4 years, there was a population that stayed the same. We had people come and go, but they tracked the people that had been there from the very beginning of the 4 years and at the 4-year mark. And they were able to show in that population, with the strategies they put in place, they were able to improve their health based on those parameters. So again, I think on a small scale, it can be done. I'm not sure how then to take that thought and open it up unless we looked at increasing the number that care coordination follows, because then we know where they are in terms of whether they follow up with their physician visits or they take their medicines. All of that stuff can be followed up on. What do you mean increasing our care coordination?
We're looking at an idea. There is an organization that's taken its name after the 7 or 8 blue zones around the world. And, just that idea in principle, does that make sense down the road to use some of that knowledge and experience? And it's being used from a wellness venue in other counties or districts in California. So we're interested in exploring this important topic from several angles.
Yeah, I think the question is, how do we make Tahoe and our district a blue zone? I think that's probably the goal, isn't it?
Well, you're segueing into something that Ted may want to chat about, or others, as we're exploring options.
Well, it was a nice soft shoe into the issue. However, it is not agendized for discussion this evening, but I do have a meeting with Harry and Louie regarding blue zones. And also there is interest, I will share, with the town manager at the town of Truckee as well. So I'll leave it at that. We're going to do some exploration.
Good.
Board education is on the agenda, though, Ted. So that's what we're talking about.
I know, but I'm watching General Counsel's furrowed brow here on my screen. I'm trying to be careful.
Mary, you've been cut off a few times. I've seen you jump. So.
Yeah, thank you. No, I was just hearkening back to Alice's example that she just used, but she started out her narrative with the word incentivized. That the employees were incentivized to do this. And unfortunately, right now, there is no financial incentive out there that I'm aware of to really make this all happen. I mean, I understand those that are capitated and how they're incented to do it and the like, but unless we want to move in that direction, I don't see how, it's that horrible phrase that strategy follows reimbursement. And it just chills me every time I hear that, but,
Yeah, Mary, I couldn't agree with you more. I'm thinking here, Apple comes out with a new iPhone with additional features, and they're incentivized to sell more phones, and the public is incentivized to buy more phones. But what is the hospitals incentive to go out and get people whose BMI is too high, lower, smoking cessation, cut down their alcohol consumption and eliminate their drug consumption, just so they won't end up at the hospital. I don't fully understand what the monetary incentive is for us as a hospital to do that.
There is zero financial incentive for us at this point as a rural area, but our love for our community drives us to do it with vigor and spend dollars annually on it for sure.
Yeah.
Like Dale, there's actually a negative incentive if we achieve the goal of optimal health for everyone in the community and they never sought the services of the hospital, then there wouldn't be a hospital. I think we're far from that goal, right? So I think we're safe, but no, that's just the fact, Mary, thanks for bringing that point up, but that is the reality we have in front of us, is that the financial incentives aren't aligned. As a health district, I think, Harry, I think that's essentially what you're saying, right? We have a relationship with the community that does encourage us, in the absence of financial incentives, to still deploy a number of programs for community benefit.
This is Bob. I think there is an incentive out there that isn't monetary, but we're a recreationally oriented community. And I think that's the incentive that we might be able to use to induce people to take a look at their health patterns and to try to improve their health patterns so that they can enjoy the recreations around them. I think that there is at least the unconfirmed, and I don't know statistically whether we can prove it, but we all know an awful lot of fit people. And since I, lived somewhere else most of my life before I came here, and I came here because there's just a lot more people who share that interest in recreational activity. And to share those recreational activities, you have to be fit. So there's a lot more fit people that I know here than I ever knew any place else I've ever lived. But somewhere, I think that is one of our goals as a community. There's a lot of interest in that. And so I think we have to look at our community in a unique way. We're not the same population that you'd see in Maryland or maybe even in Reno. So I think that's our hook, as far as I can see.
Yeah. Where I've seen success, in health systems across the country is we as a health system don't have to take the financial risk or even the burden. A lot of successful programs partnering with other community assets, I'll say. Those could be other non-for-profits, whether it's churches or schools, but also local businesses, right? And so the health system becomes the quarterback or the knowledge base for such change, but the actual driver or implementation comes from other businesses that do have an incentive or that do have a financial gain from a healthier community. So I think a lot of room for creativity, for sure.
If I could just add, I think where we're going to see some of the incentive come in the state of California is when at some point California is going to want to see the disparate health information exchanges come together, right? So right now we have Sac Valley MedShare, we have Inland Empire, there's a number of them throughout the state. And California does have that incentive because, of course, the large Medi-Cal population and the costs that surround that. So I think what we're going to eventually see is a statewide HIE with a back-end tool for analytics that we will all eventually be able to utilize. And then as a health system here locally, we'll be able to actually take that regional data and start addressing the needs of the community with meaningful data without having to go through, sometimes weeks or months of a project to just find one specific target area. We'll be able to run data that can support decision-making. And instead of spending all the cost on collecting the data, it's spending the cost on doing something about the data. Now, timing on that Not sure. There's a bit of speculation there as well, but I think that's the incentive, is when California comes together to kind of offset some of the Medi-Cal costs.
One of the things that one of the largest payers in California is doing is developing an algorithm for a health score on all of their enrollees. And, with the goal of how can we engage their various diverse resources as well. And this is a topic I've talked about over more than 10 years ago. And because it is one of the ways where you can, look at your own population and see, well, is that team score of the patients we touch, is that tide rising? Is that number improving or not? It's a very difficult score, because if you have homeless or people with food or housing insecurity, how do you fairly include those versus a population where everybody's gainfully employed? But a health score is something that has been looked at too. So there's many angles to kind of judge an organization's success over time.
And I think Michael brought up a good point about partnering with businesses, because certainly businesses can incentivize their employees. And I think if we got into a partnership with the businesses in the area, that we could get that population to look at that population in terms of improving their health, because maybe their businesses would have less sick days, less accidents, all the things that happen when you have an unhealthy population. It's a thought in terms of trying to build into a population of health.
Harry, what are the financial reimbursements or resources for preventative health care? I mean, if you go to your primary care physician, like for a checkup, but you're not going in because you're not sick, you don't have something that doesn't work or is broken. What are the options to, look at the preventive care, the thing that would say, okay, well, you could be doing this and this and this, and you're not sick now, but you could be even healthier. How does that work?
Fortunately, within the last 5 to 10 years, many plans, including governmental plans, have added a few kind of more proactive health screening kinds of things, only one of which would be mammogram, for example. So there's a list of them. They didn't used to be included, and none were reimbursable, and there was a lot of denials of visits that really tilted towards more of a rule out kind of thing, or wellness. So there is a little bit of progress in that front. And again, in a capitated world, there is enormous incentives, again, and we're not in that world, where you should be doing every kind of monitoring process available, including making sure that your enrollees have housing and food, because that's going to cost you a lot of money long term. And so there's a little bit of progress, but a lot of silos in this model today.
A lot to talk about, a lot to think about. Not a whole lot we're going to accomplish tonight, but it gets the real thinking. And one of the goals of the board was to develop an ad hoc committee, and we still have to formulate, the goals, et cetera. But both Mary and Michael have had an interest in looking at population health. And at our board retreat, we wanted to look at some various populations and what their health needs are and what kind of resources we've used. So they've got some issues that they can look at and maybe come back with some recommendations to the board at the end of their research and say, this is what we think we can focus on. So again, that's still incoming. We haven't gotten that all ironed out in terms of when to start it and how long it'll last and what the goals and outcomes should be from the committee. But it'll be like a process improvement one. So any comments? Harry smiling.
It's a good thing.
Yeah.
Yeah.
Okay, we're going to move on to item 16. We didn't pull anything. Any board committee reports?
Yes, Finance Committee, consisting of Mary Brown and me, met with Crystal and her portions of her team, ostensibly to review AR, and Mary, I think you'll agree, there's been some pretty good progress in improving AR.
Yeah, I would agree. Directionally, it's certainly improving.
Yeah, and we were kind of stymied there for a while. We haven't completely met the goals that will give us the smiley face on the monthly report, but we're getting there. And as Mary says, the direction is good. We also met with Chandler Investments, who are handling $80 million of our funds. Unfortunately, we invested at a period of time when interest rates started to rise and the asset value of our money went down a little bit, but they're still managing it well, trading out of some, taking a loss, but going into to financial instruments that pay a higher rate of return. So, those of you who have an investment portfolio know what's going on right now. And in my lifetime, I've seen many ups and downs, so I'm not particularly overly concerned at this point. We did ask them, because the information they provided us was lengthy and detailed. And I mean, it included a lot of things about national financial trends, the workings of the interest rates, increases, and so forth. A level of detail that Mary and I found fascinating, but at the end of the year, we've asked them to put together a one-page summary for your review, because I don't think any of you, you'll have the opportunity to see the detail if you want, but a one-page summary I think would be helpful. And they said that several of their clients asked for something similar, so it's not out of the ordinary. I think that's all we covered, wasn't it, Mary?
That's a bit, that was, but it took 2 hours.
Yeah, it did. we talked a long time. So, and by the way, for those of you, I assume you all looked at the figures for March. My God, the volume is off the charts. Up 29% in gross revenue. Absolutely phenomenal. Yeah. As Harry said in his synopsis, April's not starting out quite as good, but there's more of April left to come. So,
Thank you very much. Also, just to remind the board that we have on the 23rd of June, we're holding that date for a budget meeting. So just put it on your calendar. The governance committee met on April the 19th, and we reviewed the questions on our board self-assessment, and we're going to continue to use those for this coming year. We reviewed the bylaws. They're going to legal counsel for review, and hopefully we can present them to the board. David just gave me a look. Hopefully we can present them for the first reading in May, and then in June we'll vote on them. We talked about the goals of our board, and we've already started. And if you've looked at your homepage on Board Effects, you'll see, I think, 3 calendars with our education, our educational events, and also our committee meetings, so that you can plan your life around all of our meetings. And last, like I said, our ad hoc committee to look at the various populations and their health needs and what resources are available is going to come from our ad hoc committee. And you received an email from the governance committee that outlined a lot of that information. Any other committees? Okay, I attended the Tahoe Institute for Rural Health Research, their annual meeting, and they still have the 2 projects on board. The first one was a cardiac motion monitor, and they've ironed out some of the kinks with the hardware, but they're still working on that. And they still need to find, I think it's 30 congestive heart failure patients to use the monitor on before they're able to take that data and go to the FDA for approval. So in the midst of all of that, they're writing a juried article on it in hopes of finding more funding, because most of their funding is gone now, and they're looking at maybe finding some grants, either from the VA or some other institutions that would be interested in it. And then the second project they have is the Mtbi, which is the traumatic brain injury, and that has morphed over the 10 years. And what they're looking at now is a non-pharmaceutical treatment for Mtbi. And one of the reasons why they're interested in it is because there's a study that's being done at UNR of individuals who at a young age had some type of head trauma and may not have suffered any kind of sequelae at the time. But what they're finding out now is they have some type of neurological disability. It may not be flagrant, but there's still something that they can do about it. So that now that particular project is looking at a non-pharmaceutical treatment plan. And they continue to work, and they continue to be very optimistic and enthusiastic about their projects. So, any other reports?
I have a question about our clinics at the ski resorts, and I was told by one of the ski patrol members that our clinic here at Palisades Tahoe has been overwhelmed to the extent that they on Saturday had to line up ambulances to take people into Truckee to the ER because there was a 2 to 3 hour wait to see a clinician. Any comments or information on that type of issue?
Director Barnett, it's Scott Baker. I can weigh in and say that having a line of rigs out front is not uncommon, especially on the weekends. People like to hurt themselves on the weekends, especially with thin snow. I had not heard any reports that anything was more than a normal wait time to see a clinician. We've been properly staffed, so it would surprise me this late in the season with relatively low ridership on the hill that we would have a longer than normal wait time. But I'll ask around and let you know what I find out.
I think one thing for board members that's really important is there has been a real elevation in recent years to following best practice trauma care as to evaluation in the field, and those that need to come soon and quickly to a proper hospital emergency room and so forth. So there's been a lot of progress and great treatment, following the best standards there, and that can result in more ambulances showing up than maybe occurred 10 years ago because the proper evidence-based standards are being followed.
A topic that I'd like to have presented to the board at some point is just to look at what the data are on our ski area accidents, severity, and so forth. Just from being out there pretty regularly, it seems like we're getting more severe incidents.
Yeah, I'd be happy to put something together. I'm there fairly regularly, having 2 kids on the ski teams there. I'm usually sitting in my car not too far from the clinic, and I like to stop in on the weekends. So I'm there fairly regularly, and we'll put together a short presentation and circle back with you.
Great, thanks so much.
Scott, just wanted to comment, and Bob would confirm this too. We've seen a slight paradigm shift in the ski population. Weekends are busy as they've always been, and after this last dump of snow, the parking lot is filled once again there at Squaw Valley, or Palisades Tahoe, excuse me. But you know, there's a lot more skiers, younger skiers, 20s, 30s, 40s, on the chairlifts midweek now. I always interview them and say, what the hell are you doing here? This is for us old guys midweek. It's a Tuesday, it's a Wednesday, it's a Thursday. What are you doing here? And they're on their cell phone and they're doing business. With COVID, our boss doesn't want us in the office, and so we come skiing and do our work in the evening or odd hours and get the job done. So, you know, it's not only that weekends are busy, but as Bob will tell you, weekdays are often quite busy too.
Yeah, you know, what's interesting, I was reading the Vail summary for their winter a few days ago, and their ridership and season passes sales were measurably larger than last year, but I have not seen the mothership from Palisades release their winter report yet, but that'll be some interesting data to dive into. But yes, we would expect their their average daily usership to go up this year, based on a decent start to the season, and certainly sales of their season passes. I think everybody's expecting that to be a little bit higher than last year. For what it's worth, we staff the Palisades Clinic relatively the same. We do staff up sometimes on the weekends, especially holiday weekends. We'll throw a few extra bodies there. We do have more fellowship students there in the midwinter than we do late winter, although I think we had a fellow there throughout most of the season this year to have an extra set of hands. So I'll pull some data and see both daily and total encounters at that clinic and see if we have anything that's out of what we expected for this year and report back.
Yeah, the other thing I'm interested in is the trend of what the injuries are.
Yeah, we don't want to get into too much of a discussion since it's not agendized, but we will have a report back. Okay, any other closing remarks? And our next board meeting is on May the 26th. And with that, I'm going to adjourn the meeting. So thank you so much and have a good evening.
Take care, everybody.
Thanks, Allison. Good night.
Hey, board members,
Recording stopped.
Before you get off, I just wanted to let you know tonight is my last board meeting as Chief Medical Officer. Harry is bringing on a nearly full-time CMO, Dr. Gary Gray. He was our consultant, and that Gary will start May 16th. I have been present at your guys' board meetings almost all the time, barring vacations or a delivery, since 2011.
Wow.
Oh my gosh, you're the best.
And you're
still the very best, Dr. Cole. And hopefully you'll be reporting on something to us, I'm sure.
So I just wanted to say thank you and good luck with all your future decisions.
Thank you.
Thank you.
Thank you, Shawnee.
Thanks, Dr. Cole.
Good night.